dear friends, BG Dental Cases is back after winter holidays, and we are ready to continue posting our content on the regular basis. We actually moved also to our new facility, our new BG Dental Academy, so I think here at this place our content will be even more better than it was before. Today is the episode number 12. If you didn't see before any of our episodes, you may use this link and you will see our playlist of BG Dental cases from 1 to 11 with a lot of useful content that we share with you absolutely for free. Today we will discuss with you a case that we can call non-prep veneers or ceramic fragments. And I will follow you through all the process of the case from planning to bonding. So let me introduce our patient. His name is Eugene, and he requested from our side to close diastema because he was not super happy with his smile, and he wanted to improve to improve his smile with restorative treatment. We analyzed smile, and we decided that in his case we can do so-called non-prep restorative treatment, and we decided to go for porcelain veneers. Honestly speaking, this particular case can be resolved by means of direct composite restoration, freehand, in very short timing. Let's say it will be about maybe 30 minutes, maybe 1 hour. But we decided to go for ceramic veneers because of one reason. Here you can see it was 2015. So that year we saw a lot of cases that were published on Facebook or Instagram by other dentists utilizing these ceramic fragment cases, and cases were really awesome. So we decided to try our best to try actually the same approach in restorative dentistry with my dental technician, to be able to understand if these non-prep veneer cases like ceramic fragments really work efficiently. So, few tips for you if you decide to close diastema. Doesn't matter if it will be ceramic restorations or it would be some composite restorations. The main tip is that you have to show to your patient the prototype of new smile. So basically for this, in this case we have few options. You can do a really efficient prototype, which is freehand composite with no bonding, no etching. You just do so-called direct mock-up. Just fill this gap with composite and see how these teeth will look like and the smile of your patient will look like, because people, they used to see themselves in mirror, for example, with this diastema for many years, but now at once they will be closed. So you just do mock-up in order not to have surprises. Another thing is you can do visual prototype if you know how to use software, the simple software like PowerPoint or Keynote. You can do some digital prototype and to see and to show to your patient and to see yourself if you are able to close diastema just by central incisors, or you have to reorganize smile frame, moving central incisors mesially, opening spaces between laterals and central incisors from the distal, so to play with proportions. In this particular case, you can see that we can do restorative treatment just by 2 central incisors, because the diastema is not so big and his native proportion of central incisors was about 75%, which means we can transform this proportion into 80% or 85%, which will be still aesthetic. If you want to know more about aesthetic dentistry, about smile makeovers, about these proportions, about planning, about veneers from A to Z, from planning to preparation to bond, I would suggest you to come to our hands-on course, All About Veneers. This is module 3 that can be participated not in order. I mean, you can go to this module separately without going to module 1 or module 2. So you can go just for module 3, All About Veneer course, 3 days, and you'll be able to do veneers after this course immediately and to understand everything related to aesthetic dentistry. So, okay, after performing prototype, we proceed with dental steps. In this case, as I mentioned before, we decided to go for non-prep procedure. So from dental perspective, this appointment was pretty simple. The only thing that I have to do is to share with my dental technician digital information that I have, like photography, and also I have to share with my dental technician information that is related to patient's color, teeth color, because in such a case we have to integrate our small ceramic fragments into color environment that patient has. So in that case you have to transfer color information precisely. And one of the best options nowadays that we can use is polarized filter. You can apply a polarized filter, you can put it to your camera to take picture, and then this picture your dental technician will upload to the software, and he may determine the color the color parameters digitally, and then he will be able to understand what type of ceramic, what type of translucency, what type of opacity, etc. to use in this case. Okay. Before I will continue with the rest of explanation, I would like to do some informational break regarding Lumineers, because non-prep veneers, as will be displayed in this case, still nowadays for some colleagues, they mess up these veneers with Lumineers. Some people, they don't know really the difference between Lumineers and veneers. So let me just give you brief information about this, because during our courses or when we communicate with our colleagues using our social medias, there were a lot of questions regarding Lumineers, etc., etc. So Lumineers is the brand, okay? So restoratively, Lumineers are simple and basic veneers. They are veneers. We have restorative construction is veneer. Veneer is the one that covers vestibular surface of the tooth, changing color, improving aesthetics, improving function in some cases. It's veneer. But Lumineer, this the same veneer but manufacturing by company, so that they call them Lumineers. But they are made of ceramic that regular veneers made. The core idea, the core, let's say, success of Lumineers, of the company that launched Lumineers to the market, was that they market patients as the final customers for that restorative facets, let's say. And the core idea, the core, let's say, it's like a beneficial idea, was that they mentioned that Lumineers are type of veneers that are non-prep. Okay, and that's why patients, they start to go to dental offices and request to do these Lumineers, because they know that Lumineers are made with non-prep procedures. So to be honest, you can do veneers non-prep as well, but to be able to do non-prep case, you have to do really prominent and proper case selection. We cannot do prepless in every single particular case. We cannot. Otherwise, especially in cases when you have crowding, rotations, when you have teeth protruded, you will do over contour, and that will be bad in the future because of the hygiene, because of the periodontal issues, because of the functional issues, and many other problematic issues as well. So if you have teeth that are plain or flat, or they are retroclined, for example, so you have actually space to add. And if you are not changing color dramatically, let's say, you can be prepless actually with veneers. And ceramic that we use for veneers is the same ceramic that people use for Lumineers. We have 3 different types of glass ceramic that we use for veneers: feldspatic, laced ceramic, lithium disilicate or lithium silicate ceramic. So all this ceramic can be also used also for lumineers. I personally, I don't know exactly what type of ceramic is used for lumineers, but for sure this is one of these three mentioned groups. By the way, I would like to ask you to participate in our dental education. Please write down in comments what is your attitude to lumineers. Maybe you have some cases with lumineers, maybe you do lumineers yourself, or maybe you have patients with lumineers and then you may have some cases when you replace these lumineers or whatever. Just share your experience, because this YouTube channel actually that you are watching right now, and this program that you are watching right now was created to share also not our experience only, but also your experience, and you can communicate to each other and to educate each other and to share experience. So write your comments, participate in discussions, and I think all of us will benefit out of this nice professional communication. Okay, so after pictures that I took, we took impressions. In this case, we have to take impressions with double cord technique, because we have to impress space in sulcus, because in case when you close diastema, veneer will have to come pretty deep from the papilla area in intraclavicular to be able to close these black triangles. So we have to give the space to dental technician. That's why we use double cord technique. Technically, it's pretty simple. We put first cord. In all our cases, the first cord is non-impregnated, dry. The size of the cord is defined by the depth of sulcus. For example, in most of the cases, let's say it will be 000 or 00 retraction cord. And then we place another cord, second cord, over the first one. And the second cord we use with a size or two sizes bigger. This second cord can be impregnated with hemostatic liquid in case, if you have case when you prep, for example, and during preparation you have some slight bleeding. So before taking impression, you can have your wet second retraction cord with hemostatic. Personally, I use Viscostat Clear by Ultradent for that means. But in most of my cases, I try to prep without bleeding. So the second cord also can be dry. So we put second cord and we wait 5-6 minutes. Then after these 5-6 minutes, we rinse our hemostatic liquid. We make this cord wet, because if it's not wet, it was dry, for example, and you have retractor, and you place the second cord and everything becomes dry. And when you will be removing the second cord, bleeding may start, because you may just deattach the gingiva because of the sticking of the cord to the gingiva. So you have to wash it out to make it wet, then dry slightly, and then you take out the second cord, and at the same time you are injecting light body into the sulcus to take a really good impression. So in this video you can see how do I remove the second cord. Then I inject light body gently straight after second cord removal. Okay, at this time assistant is mixing putty material. If you don't have this auto mixer, so assistant is mixing right now putty material, also injects light body into the tray. Then I finish injecting light body to the teeth. I cover all the teeth with the light body dry, and then we go with impression. So actually we are using single step technique. Then this impression goes to the dental technician, and simultaneously with this impression, nightmare comes to dental lab as well. Why I'm saying nightmare? Because imagine that your dental technician will have to do really small ceramic fragments that can be 0.1 thick, and they're super brittle, and he has to be extremely accurate when he makes layering process, and especially when he will take these veneers out of the model and do shaping and polishing. That is super difficult, because these constructions are super brittle and thin. Okay, so he called me a few times from the dental lab and was complaining why I don't like him so much, that gave such a difficult work. I'm kidding, but actually it was super difficult. And then he called me back when the case was finished. He called me back and said, now Nightmare goes to dental office because now is your turn to bond these small veneers. And he was completely right, because even during try-in procedure, it was super stressful, because imagine it's 0.1 few pieces of ceramic which can be broken by tips of your fingers during similar procedure of try-in. And instead of 2, you may have 3 or 4 veneers. So you have to be super careful. In this case, since we are not changing color, we were using just simple water for try-in to see if we have optical integration or we don't. And after that we made isolation with RUBBERDAM. In this case we used floss ties that were bended to the frame. You may use also clamps that are also super efficient to retract RUBBERDAM and soft tissues. And then we bond these restorations with resin cement. The result that you can see now was achieved after few appointments and few sessions of polishing. And to be honest with you, once I bonded these veneers, I was pretty upset, because I was able to see optical difference between the ceramic fragment and tooth. So I polished it once, then I decided to ask my patient to come back in 3 days and to polish these transitions again. And this is the result that we got. And still, with that result, you may see optical difference. Okay, here you can see the optical difference, because the reason is not the veneers were bad or fit was not correct or whatever. The reason is that the index of light refraction of ceramic is different than index of light refraction of the tooth. That's why we have this optical difference. This optical difference you will be not able to see in a regular patient's environment when teeth are wet, but you can see that only in dry environment when you dry teeth and you take micro picture with a twin or ring flash. In this case you may see the difference. Okay, I was upset because at that time I didn't take into consideration the fact of index of refraction. I took into consideration pictures that I saw from Facebook, and I didn't realize that maybe somebody may use Photoshop just to mask this optical difference. Okay, and after getting some knowledge, I was pretty happy with the result that we actually achieved. Few tips that I would like to share with you. If you have these similar cases, the tip to make really smooth color transition is that when you bond your veneer ceramic fragment with resin cement, then you take immediately direct composite, and then you spread this direct composite with a thin layer over area around the veneer. So you bond this composite to the tooth, and then you polish from tooth to composite to ceramic, and then back. Okay, so in such a case you may get proper, or not proper, let's say better color and optical integration. So this is the picture. This picture was taken in red after polishing, and we have result here. This picture exactly that you can see right now was taken a few days ago before we filmed this video lesson, because we got our patient for a checkup. And you can see that this picture was taken before doing dental hygiene, because you can see a lot of plaque around his teeth in cervical area. You can see some plaque here, discoloration, etc. You can see some discolorated, no, actually it's not discolorated, this is optical difference in composite that I said that we spread a little bit, and you can see also a little bit of ceramic veneers with this dental photography. Teeth are dry, as I mentioned. The macro picture, you will always be able to see this optical difference. But to be honest, after 5 years with no dental hygiene, everything looks not bad. It's nice. The integration is nice, especially when you have this patient talking to you from the social distance. You will be not able to see the difference. So basically these non-prep things, they work even if they are thin. So people, they used to think that they will break. They will not break if you bond them to enamel with a proper bonding procedure, following instructions, following steps, and the spacer is thin. Your dental lab was doing really good work in terms of the fit, etc. So these veneers may stay. But I would like to share with you also few thoughts or conclusions regarding similar cases from my side, from my experience. First, these kind of cases can be resolved in more easier way with direct composite restorations within one appointment, within 1 hour. This is completely truth. So now if I will have the same case, I will do direct composite restoration. It's faster, easier, and cheaper for the patient. If you want to learn about composite restorations in most practical and efficient way, I would invite you to our module 2, all about composites and RUBBERDAMology, and you will learn direct, indirect, and semi-direct technique for anterior and posterior teeth. That was advertisement. Okay, so another conclusion: you will always have optical difference, so don't be upset in such a cases with the ceramic and also with composites as well, because the index of refraction of composite material is slightly different than enamel has, but less than ceramic, by the way. Another conclusion: now I prefer to do, even in non-prep cases, I prefer to do just thin margin, just small finish line, 0.2, 0.3 millimeters. The reason why is that if I have finish line, I can guide my dental technician exactly where veneer may start or where he has to finish his veneer. So it will be easier for your dental technician to define the margin. For me, it will be easier to position veneers when I do try-in, because finish line will guide me regarding proper insertion and proper position of the veneer. Okay, the finish line will guide me when I will do isolation, so I can see if I exposed finish line or I didn't expose finish line, and I have to try my best to do this. It will be easy for me when I place my veneer with cement, then to remove the cement and to polish transition, and it will be better in terms of marginal discoloration when you have small finish line. So this is some conclusions that I have from my experience. I really like to work with non-prep cases because they are easy, just take impression, that's it. But I do now small finish line to make my life and the life of my dental technician easier. Okay, so one more time, if you want to learn more about veneers, module 3 will be more than welcome to see you here in Kiev. All about composites, module 2, and you'll be pro in veneers and in composite restorations. Don't forget to write down your comments and thoughts about Lumineers and your experience with these, okay? And I think that we are done for today. I will be more than happy to see you next time in BG Dental case number 13. I don't know which topic I will be rising up. I think that will be some interesting things with tips and tricks. So guys, it was really nice to work for you, and let's see you next time. Bye bye.